And then next we have Holger Schünemann. He's chair of the Department of Health Research Methods, Evidence, and Impact at McMaster University, co-chair of the GRADE Working Group, director of Cochrane Canada, co-chair of the Guidelines International Network Janata Working Group, and he has worked with many different guideline panels, including WHO and lots of professional societies, and he'll be talking about GRADE.
Yeah, thanks very much, Roger, for the introduction, and thanks very much for having me. I will shift gears quite dramatically. I think I was asked a lot of questions and was supposed to address all of them. That will be very difficult, I think, but I believe that there is possibly some helpful information in here, and then that will lead to further discussion. So these are my disclosures. That is just for the public record. Then there is no financial conflicts of interest with regards to what I'm speaking about. And there were a lot of issues, as I described, that I was supposed to address. So provide a little bit of background about a framework that has been utilized, by the way, in pain guidelines and opioid guidelines in Canada successfully. But my examples will not so much refer to pain and opioid use for a very good reason, because I don't want to get entangled in content as opposed to talking about frameworks. Then talking about what makes us certain in evidence, use of indirect evidence, which is probably very necessary in this particular context, and then a few other selected topics. So, but what I found was very important, and that really became evident as we went through the day. What I found important is to distinguish between a framework and approach for guideline development and the actual framework for the development of the questions within the guideline and the analytical frameworks. And I think, to me at least, that has been mixed up a little bit during the discussion over the day. So I'll try to address these two things. So I was asked in particular why this great framework couldn't be used potentially in the effort that the FDA is asking you to accomplish or to conduct. So the GRADE Working Group is a group that has been working for 20 years on developing frameworks for different types of guidelines. The approach is supposed to be a unifying, transparent, and sensible approach for rating the certainty of evidence and making decisions in guidelines. It's used by over 100 societies, including the World Health Organization, CDC, many professional societies. It's used for evidence synthesis and the development of recommendations in practice guidelines. There's literally thousands of recommendations, probably over 10,000 recommendations that have been developed with this approach. That doesn't mean that it answers all the fine questions or the details that may be necessary for a opioid guideline, but the guiding principles and the operationalization of the approach is there. We have over 40,000 citations to our work. There's a detailed handbook that is consistent with the IOM standards, and there's an IT application. And basically, this framework works as follows. There's a group that is interested, a panel typically, that is interested in making a recommendation or a decision, and it starts with developing a healthcare question, and a lot of questions were discussed during the day by the many experts who are here. We typically use the population intervention comparator and outcomes framework. And I was also asked, how does GRADE deal with outcomes that are more important for decision-making, those that are less important for decision-making? And the approach that we are utilizing is that we look at which outcomes are critical for decision-making. So, for instance, under those particular circumstances, pain reduction, potential side effects, and then there are those that might be less important, such as constipation. They are not unimportant, but they may be less important. A literature review would be conducted. The outcome rating follows an established approach. We use fairly simple scales. You can use more complicated methods such as utility scales, but we essentially say that we should focus on both desirable outcomes such as better quality of life, reduced pain, and undesirable outcomes such as the potential severe side effects that could result from addiction. And we bring those together then to evaluate the benefits and harms. We do one further thing that came up a bit earlier in a question, and that related to we shouldn't just rate pain on a 1 to 10 scale. We use something that we call health outcome descriptors, so that both or all patients, providers, and guideline developers can agree on what an outcome really means. So we use these brief descriptors, for instance, for chronic moderate pain. We've applied this successfully, this principle, in a big guideline effort that we just finished with the American Society of Hematology. So moving on, when that type of literature review is done, we synthesize evidence in what we call evidence profiles, a summary of findings tables, and rate the certainty of the evidence. That can be displayed, as I said, in various ways. We have these interactive summary of findings tables that both serve practitioners, that include graphical representation. This is not an opioid or pain example, but where we essentially describe the evidence for an outcome and what the underlying certainty of, for instance, an intervention effect is. So the certainty is evaluated according to standard principles. There are essentially 8 criteria or domains. How well is the research done? That includes registry studies or observational studies. It includes how consistent is the research. We call that inconsistency. How directly do the results relate to the question of interest, that PICO question of interest? That could include a dosing question or how many pills should be given. And we call that indirectness or applicability, obviously. Is the effect size precise or due to random error? That is imprecision. And then are these all of the studies that have been conducted, and we call that publication bias. And then there are 3 domains that lead to increasing the certainty, and I was specifically asked to talk about that. That relates to large effects when the worst case scenario still predicts a strong conclusion, and when there are exposure-effect relations. And all of these domains have been operationalized in great detail. There are several papers that can be utilized to operationalize, as I said, and apply these domains. So increasing the certainty based on the literature that is out there has to do with how large the, for instance, relative treatment effects or absolute treatment effects may be. And again, a specific criterion that relates to, and that may be applicable here, to when residual opposing plausible confounding still predicts an outcome. So in other words, an example would be that only those with severe pain and poor predictors of good outcomes who are treated with opioids, but opioids still provide net desirable consequences compared with the alternatives. So when the research predicts that it shouldn't work, but it does work, that's kind of that type of example. I was asked what else could lead to rating up the certainty. We've spent 20 years now on that question, so very happy to understand what other factors might increase the certainty, for instance, in intervention effects, and then grade would have to be modified. The other question that I was asked about is how indirect evidence can be utilized, and there were lots of questions brought up about, for instance, children in this context. We use standardized instruments, applicability instruments, to rate the certainty or rate the evidence, and then draw conclusions with an expert panel, these applicability instruments. Indirectness or applicability affects all of these domains: population, the intervention, the type of dosing, the comparator that we're interested in, and the outcomes. So also there, for these other domains, the outcomes and the population and the comparators, we would be utilizing those type of instruments. I'll give you a very quick example. This is actually from these ASH guidelines that are described, where a lot of indirect evidence was utilized, for instance, to make recommendations about anticoagulant treatment for the pediatric population. And that just, again, to show you how this could look, this particular panel made a strong recommendation for the use of anticoagulants for a specific condition, but and described why it made a strong recommendation despite the fact that there was very little evidence from children, that indirect evidence actually could be utilized to draw strong conclusions. And at the same time, when evidence is indirect, so not the direct evidence for that population that you're interested in, you may often say there is low certainty in our decision, but the decision is still the right decision under the circumstances that we have. And then this indirectness rating is done across different studies. Just moving on with these evidence tables, we then utilize evidence to decision frameworks. Those are criteria that are utilized to make a decision or recommendation either for or against an option. These frameworks include a detailed question, an assessment of the individual criteria, a conclusion section including research considerations, and a presentation to stakeholders. We call them interactive evidence to decision frameworks. And just so that you see what that means, these frameworks help decision makers to be informed about judgments about the pros and cons of an option, considering each important factor that determines the recommendation is emphasized with these frameworks. They provide a concise summary of the best available research evidence, and they help to structure the discussion of a panel that makes a recommendation. And it identifies disagreement. And they are for different target audiences. This is essentially how the criteria work, or what these criteria are. So it deals with how important is the problem. So, for instance, the baseline risk or the prevalence of, for instance, opioid use. It deals with balancing the benefits and harms, and then assessing the certainty according to what I described, assigning values or the importance to these outcomes that we are dealing with and are balancing with. It can include factors such as resource use, equity, applicability, and acceptability and feasibility considerations. And just to emphasize that point, I was asked to talk about how does GRADE deal with different outcomes, with the importance of different outcomes. I already spoke about that. We would value the importance of the outcome, because without doing that, if you have similar effect estimates, you would not be able to actually do that. So, for instance, severe pain may be more important than constipation, and therefore, if those were the only two outcomes that were affected by opioids, which they are not, I understand that, then we would say, okay, under those circumstances, we would favor pain and would favor making a recommendation in favor. And that is separate, again, that framework that I just described, and this is where I will conclude. That framework is quite different from an analytical framework or pathway for developing relevant questions that deal with opioid use. And I think really that needs to be kept separate. Frameworks for guideline development have been applied successfully for many, many years by many, many groups. This issue is a different issue, and that is how to identify the appropriate questions. And that's my final slide. So all of that then leads to a transparent guideline recommendation when these criteria are appropriately considered and judgments are made by a panel. Thank you.